Hello friends, today we are going to discuss the ESC guidelines of management of acute coronary syndrome which was published in 2023. So we'll start with definition. So the definition of acute coronary syndrome and myocardial infarction. Acute coronary syndrome encompasses the spectrum of conditions that include patients presenting with the recent changes in the clinical symptoms and signs, with or without changes in the 12-lead ECG, and with or without acute elevation in cardiac troponin concentration. So patients presenting with the suspected acute coronary syndrome may eventually receive the diagnosis of acute myocardial infarction and unstable angina. The diagnosis of acute myocardial infarction is associated with the cardiac troponin release and is made on the basis of the fourth universal definition of MI. An unstable angina is defined as myocardial ischemia at rest or minimal exertion in the absence of acute cardiomyocyte injury or necrosis, and it is characterized by specific clinical finding of prolonged angina that is more than 20 minutes at rest and new onset severe angina that is increasing in frequency, longer in duration, lower in threshold, or angina that occurs after recurrent episode of MI. So this is the spectrum of ACS. So clinically, it can be patient can be asymptomatic. Then there can be the increasing chest pain, persistent chest pain and symptoms. Then cardiogenic shock, acute heart failure, and patient may present as cardiac arrest. So these are the ECG findings. The ECG could be normal, or there could be ST depression, ST elevation, or patient can present in the malignant arrhythmias. So according to the working diagnosis, the patient is divided into NSTEMI and STEMI. In NSTEMI, this HS tropi level will be normal, or in NSTEMI it will be elevated, and in unstable angina the markers will be normal. So, acute myocardial infarction is defined as cardiomyopathy, cardiomyocyte necrosis in clinical setting of acute myocardial ischemia. This includes myocardial infarction due to atherosclerotic event, that is type 1. It is also the potential causes of myocardial ischemia and myocardial necrosis in the type 2 to type 5. So, myocardial injury is the another distinct entity used to describe troponin release due to mechanism other than myocardial ischemia not meeting the criteria for the myocardial infarction. So these are the some definition of terms that we are used in this document, like first medical context. That means the time when patient is initially assessed by physician, paramedic, nurse, and other trained emergency medical service worker who can obtain and interpret the ECG and deliver the initial intervention. So the first medical contact can be either pre-hospital setting or upon the patient arrival at hospital. Then, regarding STEMI diagnosis, the time at which the patient with ischemic symptom is interpreted as presenting with ACS and ST segment elevation. Then, primary PCI, the emergent PCI with balloon stent and the other appropriate device performed on the ischemia related artery without previous fibrinolytic treatment. Then primary PCI strategy, that means emergency coronary angiography and PCI of infarct-related artery is indicated. Then the next is rescue PCI. Then emergency PCI performed as soon as possible in case of failed fibrinolytic treatment. Then routine early PCI strategy after fibrinolysis. That is coronary angiography with PCI of infarct-related artery, if indicated, performed between 2 hours and 24 hours after successful fibrinolysis. Then the next is pharmacoinvasive strategy, that is fibrinolysis combined with rescue PCR or routinely early PCR strategy. Then there is a immediate invasive strategy, that is emergent coronary angiography and PCI and CABG of infarct-related artery if indicated. Early invasive strategy, early coronary angiography and PCI CABG of infarct-related artery if indicated. Then selective invasive strategy, coronary angiography plus PCI and CABG based on clinical assessment or non-invasive testing. Now, this is the classification of the patient. So regarding the clinical presentation, ECG, if the patient had signs and symptoms suggestive of the ACS, perform ECG within the 10 minutes of first medical contact. Then, based on the ECG and symptoms, the patient is divided into STEMI and NSTEMI. In NSTEMI, ECG will be normal and STEMI will present with the specific ECG findings. Then the further step is the cardiac biomarker, the HS troponin. We have to send the HS troponin level, angiography, and imaging. And then we need to divide the final diagnosis into STEMI, NSTEMI, and unstable angina. So, regarding the clinical presentation and physical examination, acute chest discomfort, which may be described as pain, pressure, tightness, heaviness, burning, is the leading presenting symptom and prompting consideration of clinical diagnosis of ACS and initiation of testing aligned with specific diagnostic algorithm. Chest pain equivalent symptom include dyspnea, epigastric pain, pain into the left and the right arm, and neck and jaw. Uh, So regarding history taking and physical examination, prompt assessment of vital sign is recommended at first medical contact. At the same time, the acquisition of the new ECG. In patient presenting with suspected ACS, physical examination is recommended and is useful both to eliminate differential diagnosis and to identify very high risk and high risk ACS feature. This may be particularly relevant for patients presenting with cardiac arrest, signs of cardiogenic shock, hemodynamic and electrical instability. Then regarding diagnostic tool and the ECG. Patient with the acute chest pain and persistent ECG elevation on ECG is diagnosed with the ST segment elevation MI. So MI will not be the final diagnosis in all patients with the working diagnosis of STEM. Now the patient with acute chest pain without persistent ST elevation on ECG. This patient may exhibit the other ECG alteration, including transient ST elevation, persistent or transient ST segment depression, T wave abnormalities, including hyperacute T wave inversion, biphasic T wave, flat T wave, pseudo-normalization of T wave. Alternatively, the ECG may be normal. So the majority of the patient in this category who subsequently display the typical rise and fall in cardiac troponin, that is fulfilling MI criteria as per the fourth universal definition of MI, will receive the final diagnosis of end-stage. In other patient, troponin levels will remain below 99 percentile and they will receive the final diagnosis of unstable angina. Now, regarding acute coronary syndrome with persistent ST elevation, new ST elevation at J point, at least two contagious leads, that is more than or equal to 2.5 mm in male, more than less than 40 years, more than or equal to 2 mm in male, more than 30 years, or more than or equal to 1.5 mm in female, regardless of age in V2, V3 or more than or equal to 1 mm in other leads in the absence of left ventricular hypertrophy or left bundle branch block. In the patient suspected with the inferior STEMI, it is recommended to take a record right precordial leads in order to assess for ST segment elevation. Posterior leads can also be recorded to investigate for posterior STEMI, particularly in patients with ongoing symptoms and inconclusive standard 12 lead ECG. Then ST segment depression in the lead V1 to V3 and ST segment elevation in V7 to V9 are highly suggestive of posterior coronary artery occlusion. ST segment elevation in V3R and V4R is highly suggestive of ongoing RV ischemia, and ST depression of more than or equal to 1 mm in more than equal to 6 surface leads coupled with ST elevation in AVR and V1 suggests the multivessel ischemia and left main coronary artery obstruction particularly if the patient presents with hemodynamic compromise. Then bundle branch block in patient with high clinical suspicion of ongoing myocardial ischemia. The presence of LBB, RBB, or pace rhythm precludes the accurate assessment of presence or absence of ST segment elevation. Therefore, patient presenting with these ECG pattern in combination with signs and symptoms that are highly suggestive of ongoing myocardial ischemia should be managed similarly to those with clear ST segment elevation, regardless of whether bundle branch is previously known. Now, acute coronary syndrome without persistent ST segment elevation. These ECG abnormalities include ST depression, T wave changes, like biphasic T wave, prominent negative T wave, that is Whelan sign, related to the severe proximal left anterior descending artery stenosis. Now we'll see what are the recommendations for clinical and diagnostic tools for patient with suspected acute coronary artery syndrome. So it is recommended to base the diagnosis and initial short-term risk stratification of ACS on the combination of clinical history, symptom, vital sign, and other physical findings, ECG and HS-troponin. This has class 1 recommendation level of evidence B. On the basis of ECG, the 12-lead ECG recording and interpretation is recommended as soon as possible at the point of first medical contact with the target of less than 10 minutes. So the continuous ECG monitoring and the availability of the defibrillator capacity is recommended as soon as possible in all patients with suspected STEMI, in suspected ACS with other ECG changes, ongoing chest pain, and once diagnosis of myocardial infarction is made. The use of additional ECG leads, that is V3R, V4R, and V7 to V9, is recommended in case of inferior STEMI, or if or if total vessel occlusion is suspected and standard leads are inconclusive. All this statement has class of recommendation 1 level of evidence B. An additional 12-lead ECG in cases of recurrent symptoms and diagnostic insight. Only this statement has class of recommendation 1 level of evidence C. Now regarding blood sampling, it is recommended to measure cardiac troponin with high sensitivity assay immediately after presentation to obtain the result within 60 minutes of the blood sampling. Class of recommendation 1 level of evidence. It is recommended to use ESC algorithm approach with serial high sensitivity cardiac troponin measurements, that is at the interval of 0 hour, 1 hour, and 2 hour to rule in and rule out NSTEM. Additional testing after 3 hours is recommended if first two HS troponin measures of 0 hour and 1 hour algorithm are inconclusive and no alternative diagnosis explaining the condition have been made. So all this statement has class of recommendation 1 level of evidence B. The use of established risk score for the prognosis for estimation should be considered. So that like Grace risk score, this has a class of recommendation 2A level of evidence B. Now the triage for emergency reperfusion strategy. It is recommended that patients with suspected STEMI are immediately triaged for emergency reperfusion strategy. Now, the regarding diagnostic biomarker, the regarding high sensitivity cardiac troponin. After excluding clinical ECG signs suggestive of STEMI or very high risk STEMI ACS, biomarker play the contemporary role in the diagnosis, risk stratification, management of patient with suspected ACS. So they said the rapid rule in and rule out algorithm. That is, we need to repeat this HS troponin at the interval of 0 to 1 hour or 0 to 2 hours. And we need to see the trend. And we can also repeat the tropi at 3 hours if the results are inconclusive. So Zero, 1 hour, and 2 hour rule in rule out algorithm using high sensitivity cardiac troponin assay in patient presenting with the emergency department with suspected NSTEMI or and without an indication of immediate and invasive angiography. So this high sensitivity troponin, so according to that, the patients are classified into one of three pathway as the result of their HS troponin at 0 hour, 1 hour, and 2 hour. So patient with very low initial HS troponin value and patient with the low initial value and no 1 hour and 2 hour changes, the HS troponin is assigned to rule out pathway. Patient with high initial HS troponin or 1 or 2 hour changes in HS troponin assigned to rule in pathway. Patients who do not meet the criteria for rule out and rule in strategy are assigned to the observation pathway. And these patients should have HS troponin checked at 3 hours plus echocardiography in order to decide about further management. Now, regarding the other biomarker, the use of biomarker other than the cardiac troponin for the diagnosis of ACS is not recommended. Among the multimode additional biomarker evaluated for diagnosis of NSTEMI, only creatinine kinase myocardial band isoenzyme, myosin binding protein C, and then copeptin may have clinical relevance when used in combination with the cardiac troponin. Now, regarding the diagnostic tools and the non-invasive imaging. Now, regarding echocardiography, this transthoracic echocardiography can be useful to identify signs suggestive of ongoing ischemia and prior MI. This transthoracic echocardiography can be useful to suggest alternative etiology associated with chest pain like aortic disease, RV signs in pulmonary embolism. So all patients presenting to cardiogenic shock or hemodynamic instability should undergo emergency transthoracic graphy to try to identify the underlying cause, in particular to assess LV and RV function and to look for the mechanical complication. Now, the computed tomography, upon clinical presentation, the CT is often the diagnostic tool of choice for ruling out alternative potential life-threatening differential diagnosis of ACS like PE and aortic dissection. And this should be the ECG gated contrast CT aortogram with full coverage of thoracic aorta and proximal head and the neck vessels. The BECON, that is better evaluation of acute chest pain with coronary computed tomography angiography study showed no reduction in hospital duration of stay and hospital admission in CCTA arm compared with patient investigated with HS troponin with similar results to those observed in ROMICAT 2 trial study and the rapid CTCA study, rapid CTCA trial. So the default approach using this coronary computed tomography as a first line imaging investigation in patient with suspected NSTEMI is therefore not recommended. And normal coronary tomography angiogram uh, has high negative predictive value to exclude ACS and is associated with the excellent clinical outcome. So this CCTAs can be used to risk stratify selected low risk NSTEMI patients. Such patients we are found to have normal coronary arteries, non-obstructive coronary artery, and distal obstructive disease, and may then not require invasive coronary angiography. So, of note, the utility of this computed tomography may be limited in patient with tachycardia, established coronary artery disease, previous stent, and the extensive coronary calcification. Now, regarding cardiac magnetic resonance imaging with or without stress testing. Now, the cardiac magnetic resonance is the imaging of choice with the poor echocardiographic window preclude the diagnostic echocardiographic evaluation. So cardiac magnetic resonance allow the direct visualization of the infarcted region, providing information on scarring and viability that can be differentiated from other forms of myocardial injury. So cardiac magnetic resonance is therefore particular clinical value in establishing diagnosis of acute myocardial infarction where there is diagnostic uncertainty. So CMR can be useful in identifying the culprit vessel territory and confirming the diagnosis of myocarditis, Takotsubo cardiomyopathy, and among other differential. So CMR is of particularly value in establishing diagnosis in patient presenting with working diagnosis of myocardial infarction with non-obstructive coronary arteries following invasive angiography and is gold standard for LV thrombus. So we'll see what are the recommendation for this non-invasive imaging. So before that, let me finish about the cardiac magnetic resonance. Cardiac magnetic resonance can also assess myocardial perfusion with pharmacological stress, and this can be used as alternative to coronary this computed tomography in the assessment of patient in observed zone following ECG and HS troponin, particularly in those with the advanced established CAD in whom assessment of the myocardial perfusion and viability may provide more useful information on CCT. Some additional information on CMR, single proton emission computerized tomography, that is SPECT perfusion imaging and stress cardiomyopathy is provided. Now the recommendation for the non-invasive imaging. Emergency, this transthoracic echocardiography is recommended in patient with suspected ACS presenting with cardiogenic shock or suspected mechanical complication. This has class of recommendation 1 and level of evidence C. In patient with suspected ACS, non-elevated HS troponin, no ECG changes, no recurrence of pain, incorporating coronary computed tomography, angiography, or non-invasive stress imaging test as a part of initial workup should be considered. This statement has class of recommendation 2A, level of evidence A. Emergency TTE should be considered at triage in the case of diagnostic uncertainty, but this should not result in delay in the transfer to cardiac catheterization lab if there is suspicion of acute coronary artery occlusion. There is a class, this has class of recommendation 2A, level of evidence C. Routine early CCTA in patient with suspected ACS is not recommended. Now, the differential diagnosis of acute chest pain, several cardiac and non-cardiac conditions may mimic ACS and should be considered in differential diagnosis of acute chest pain. Now, the initial measures for patient with the presenting with the suspected acute coronary syndrome. Now, the regarding pre-hospital logistic care, patients with the suspected ACS are initially categorized on the basis of 12 ECG and triage into the two initial treatment pathways. One for patient with ECG consistent with STEMI and one for patient without STEMI elevation or equivalent ECG pattern. Now, the time to treatment. The treatment time reflects the efficacy and quality of care system, taking care of patient and suspected state. Now, regarding the role of emergency medical services at national level, EMS with easily recalled and well published unique medical dispatch number, that is 112 for European Union countries, is important to speed up system activation. Now, regarding the role of a general practitioner, the responsibility of the primary care clinician may include diagnosis, activation of EMS, risk stratification, initiation of pre-hospital treatment. However, in most settings, consultation with general practitioner instead of direct call to EMS will increase pre-hospital delay. Now, the organization of ST segment elevation myocardial treatment network. PCI Center is a multidisciplinary acute care center that provides emergency invasive management 24/7 for patient presenting with suspected STEM. The recommendation should develop protocol for rapid fibrinolysis at place of STEMI diagnosis with aim of treatment within 10 minutes of first medical contact, followed by immediate transfer to center with 24/7 service for PC. Now regarding emergency care, initial diagnosis and monitoring. Based on symptom consistent with myocardial ischemia signs on 12-lead ECG, it is recommended to initiate ECG monitoring as soon as possible in all patients with suspected ECS in order to detect life-threatening arrhythmia and to allow prompt defibrillation if indicated. Now regarding acute pharmacotherapy, oxygen. Oxygen supplementation is recommended in ECS patient with hypoxemia that is less than 90%, and oxygen supplementation in patients who are not hypoxic is not associated with clinical benefit and therefore is not recommended. Now regarding nitrates, sublingual nitrates may be helpful to relieve ischemic symptoms. In patients with ECG compatible with ongoing STEMI and symptom relief after NTJ administration is recommended to obtain another 12-lead ECG. Complete normalization of ST segment elevation along with the relief of symptom after nitroglycerin administration is suggestive of coronary spasm with or without associated M. So nitrate should not be given to patient with hypotension, marked bradycardia, tachycardia, RV infarction, and known severe aortic stenosis, phosphodiesterase 5 inhibitor use within the previous 24 to 48 hours. Now regarding pain relief, the intravenous opioids that is morphine of 5 to 10 mg should be considered for the relief of severe chest pain. However, morphine may enhances the nausea and vomiting and slow gastrointestinal absorption of oral medicine, which may delay the onset of action of oral administered antiplatelet therapy. So, morphine may also reduce myocardial and microvascular damage when given to patient with ongoing coronary artery occlusion, though co-administered with metoclopramide appear to negate this effect. So the positive effect of the morphine on myocardial damage may potentially related to the reduced oxygen consumption as a result of decreased preload and negative inotropic and chronotropic. So morphine may also further reduce the absorption, delay the onset of action, and decrease the antiplatelet effect of oral P2Y12 receptor inhibition in MI patient. Although this effect may vary between the different P2Y12 inhibitors. Now regarding intravenous beta blocker. The intravenous beta blocker, preferably metoprolol, should be considered at the time of presentation in patient with working diagnosis of STEMI undergoing primary PCI with no signs of acute heart failure, systolic blood pressure more than 120, and without other contraindications. So administration of IV beta blocker in patient with the suspected NSTEMI has not been tested. So we'll see what are the recommendations for initial treatment, initial management of the patient with acute coronary syndrome. So first is if the patient is hypoxic, oxygen is recommended in patient with hypoxia. That is, this treatment has class of recommendation 1, level of evidence C. Routine oxygenation is not recommended in patient without hypoxemia. That is, it has a class of recommendation 3, level of evidence A. Now regarding symptoms, intravenous opioid should be considered to relieve pain and mild tranquilizer should be considered in very anxious patient. This has class of recommendation 2A, level of evidence C. Intravenous beta blocker should be considered at the time of presentation in patient undergoing PCI with no signs of acute heart failure, systolic blood pressure more than 120, and no other contraindication. Class of recommendation 2A, level of evidence A. Pre-hospital logistic care. It is recommended that pre-hospital management of patients with working diagnosis of STEMI is based on regional network designed to deliver the reperfusion therapy expeditiously and effectively with effort made to make PCI available to as many patients as possible. Class of recommendation 1, level of evidence B. It is recommended that PCI capable center deliver the 24/7 service and are able to perform PCI without delay. Class of recommendation 1, level of evidence B. It is recommended that patient transferred for PCI bypass the emergency department CCO and are transferred directly to catheterization lab. Class of recommendation 1, level of evidence B. It is recommended that EMS transfer the patient with suspected STEMI to PCI center bypassing non-PCI center. And it is also recommended that ambulance team are trained and equipped to identify ECG pattern suggestive of acute coronary artery occlusion and to administer initial therapy, including defibrillator fibrinolysis when applicable. It is recommended that all hospital and EMS participating in the care of patient with suspected STEMI record and audit delay time and work together to achieve and maintain quality target. Both of these statement has class of recommendation 1, level of evidence C. Now regarding acute phase management of patient with acute coronary syndrome. Now regarding selection of invasive strategy and reperfusion strategy. Patient with working diagnosis of STEMI, these patients should be triaged for immediate working reperfusion strategy. That is PCI strategy or fibrinolysis if PCI is not possible within 120 minutes of diagnosis. Patient with working diagnosis of NSTEMI, for these patients, an inpatient invasive strategy is recommended. Immediate invasive strategy is recommended when any very high risk is present, and early invasive strategy should be considered when any high risk features are present. That is within 24 hours if there is high risk, and immediate invasive when the high risk features are present. So acute coronary syndrome managed with the invasive strategy. Invasive management strategies are the time sensitive, and it is recommended that patient triage to immediate invasive strategy, that is those with the high suspicion of ongoing acute coronary artery occlusion, persistent ST segment elevation, and NSTEMI with any very high risk characteristic receive emergency angiography as soon as possible. High risk NSTEMI patient that is ruled in STEMI as per 0, 1 hour and 0, 2 hour algorithm with dynamic ST and T wave changes with transient ST elevation and with the gray score of more than 140 should be considered for early invasive strategy, that is within 24 hours. Now the primary percutaneous coronary intervention strategy for ST segment elevation myocardial infarction. In patient with working diagnosis of STEMI, the PCI strategy is preferred reperfusion strategy provided it can be performed in timely manner. That is within 120 minutes of ECG based diagnosis. However, in some circumstances, PCI is not immediate option and fibrinolysis should be initiated as a part of pharmacoinvasive therapy provided the patient has presented within 12 hours of symptoms. For simplicity, absolute time of 120 minutes from STEMI diagnosis to PCI mediated reperfusion rather than relative PCI related delay over fibrinolysis has been chosen. Given the recommended time interval of 10 minutes from STEMI diagnosis to administration of bolus fibrinolytic and 120-minute absolute time delay would be correspond to relative PCI related delay in the range of 110 to 120 minutes. For patients who undergo fibrinolysis, rescue PCI is indicated if fibrinolysis fails. That is, ST segment resolution of less than 50% within 60 to 90 minutes of fibrinolytic therapy and in presence of hemodynamic and electrical instability, worsening ischemia, and persistent chest pain. Patient with successful fibrinolysis should undergo early invasive angiography, that is within 2 to 24 hours from time to lighting bolus injection. And a patient with working diagnosis of STEMI who presented to non-PCI center should immediately transfer to PCI capable center. For a patient with the working diagnosis of STEMI who presented to the non-PCI center should be immediately transferred to the PCI capable center for timely PCI strategy. If PCI is not feasible within the 120 minutes, the patient should undergo immediate fibrinolysis followed by transfer to PCI center without warning signs of reperfusion. For patient presenting after 12 hours of symptom onset, PCI strategy is preferred over fibrinolysis in all cases. Then emergency coronary artery bypass grafting surgery should be considered for patient with patent infarct related artery, but with unsuitable anatomy for the PCI and either large myocardial area at geopardy or with cardiogenic shock. In patient with MI related mechanical complication and who are coronary and who require coronary revascularization, CABG is recommended at the time of surgical. Now, the stable patient with persistent occlusion of infarct-related artery, 3 to 28 days after MI. The occluded arterial trial reported no clinical benefit from routine coronary intervention with medical management in comparison to the medical management alone. Therefore, routine PCI of occluded infarct-related artery in STEMI patient presenting with more than 48 hours of symptom is not indicated. Now, immediate invasive strategy for ST elevation in acute coronary artery syndrome. Immediate invasive strategy refers to the emergency angiography and PCI indicated. This is recommended for patient with working diagnosis of STEMI and any of the following. High risk criteria, that is hemodynamic instability, recurrent ongoing chest pain refractory to medical management, acute heart failure presumed secondary to ongoing myocardial ischemia, life-threatening arrhythmia, or cardiac arrest after presentation, mechanical complication, recurrent dynamic ECG changes suggestive of ischemia. Then early or delayed invasive strategy for NSTEMI, acute coronary syndrome. An early invasive strategy refers to the routine invasive angiography within 24 hours of presentation. This should be considered in patient with working diagnosis of NSTEMI and any of the following high risk criteria. Confirmed diagnosis of NSTEMI based on the current recommended ESC HS troponin algorithm, dynamic ST T-wave changes, transient ST elevation, and gray score of more than 140. Now the summary of invasive strategies for patient with NSTEMI. Now the selection of invasive strategy and reperfusion therapy in patient with NSTEMI, acute coronary artery syndrome. So this NSTEM So we need to if the patient is presenting with the symptom of ACS and ECG is consistent with NSTEMI, and the first medical contact is non-PCI center, can be non-PCI center, ambulance or PCI center. So we need to classify the patient into the categories like very high risk, and non-high risk. So if the patient is in very high risk, that means if the patient is hemodynamically unstable or cardiogenic shock, recurrent or ongoing chest pain refractory to medical treatment, acute heart failure presumptive secondary to ongoing myocardial ischemia, life-threatening arrhythmia or cardiac arrest after presentation, mechanical complication, and recurrent dynamic ECG changes suggestive of ischemia, then we need to go for immediate invasive surgery. If the patient is in high risk, that is confirmed diagnosis of NSTEMI based on ESC algorithm, gray score more than 140, dynamic ST segment elevation, dynamic ST segment and T-wave invasion, then we need to consider for the early invasive strategy, that is within 24 hours. And if the patient is a non-high risk, that is in patient without very high risk and high risk feature and low index of suspicion, then we need to go for selective invasive strategy. Now regarding fibrinolysis and pharmacoinvasive strategy in patient with ST segment elevation. Fibrinolytic therapy is important reperfusion strategy for a STEMI patient presenting within 12 hours of symptom onset when PCI cannot be performed in timely manner, or it prevents the 30 early death per 1,000 patient treated within the 6 hours of symptom. So successful reperfusion is generally associated with significant improvement in ischemic symptom, more than 50% of ST segment resolution and hemodynamic instability and hemodynamic stability. So the doses of fibrinolytic agent and concomitant antithrombotic therapies are given in fibrinolysis, and pharmacoinvasive strategies are provided in we will be discussing in subsequent discussion. So in pre-hospital fibrinolysis, fibrin-specific agent, that is tenecteplase, alteplase, retiplase, is preferred agent, and the goal is to start fibrinolytic therapy within 10 minutes of STEMI diagnosis. So this fibrinolytic therapy initiation should not be delayed by waiting for the result of cardiac biomarker testing. The STREAM trial demonstrated that pre-hospital fibrinolysis followed by early PCI strategy was associated with similar outcome to transfer for PCL in STEMI patient presenting within the 3 hour of symptom onset who could not undergo PCI within 1 hour of first medical contact, although slight excess of intracranial bleeding was observed in the investigational strategy. Now regarding angiography and percutaneous coronary intervention after fibrinolysis. In case of failed fibrinolysis and evidence of reocclusion or reinfarction with recurrence of ST segment elevation, immediate angiography and rescue PCI are indicated. So in this setting, the readministration of fibrinolysis is not beneficial and is discouraged. Even if it is likely that fibrinolysis is successful, that means ST segment resolution of more than 50% at 60 to 90 minutes, typical reperfusion arrhythmia and disappearance of chest pain. Routine early angiography within 2 to 24 hours is recommended. Several randomized trials have shown that routine early angiography with subsequent PCI after fibrinolysis reduces rate of reinfarction and recurrent ischemia in comparison to the watchful waiting strategy. So we will see the recommendations now. So reperfusion therapy is recommended in all patients with working diagnosis of STEMI and symptoms of ischemia less than 12 hours of duration. So this statement has class of recommendation 1, level of evidence C. PCI strategy is recommended over fibrinolysis if anticipated time from diagnosis to PCI is less than 120 minutes. Class of recommendation 1, level of evidence A. If timely PCI within the 120-minute cannot be performed in patient with working diagnosis of STEMI, then fibrinolytic therapy is recommended within the 12 hours of symptom onset in patient without contraindication. Class of recommendation 1, level of evidence C. Then rescue PCI is recommended for failed fibrinolysis. That means ST segment resolution of less than failed fibrinolysis means ST segment is not resolved of ST segment resolution is less than 50% within 60 to 90 minutes of fibrinolytic administration and in presence of hemodynamic and electrical instability, worsening ischemia and persistent chest. So in patient with working diagnosis of STEMI and time from symptom onset is more than 12 hours, PCI strategy is recommended in the presence of Ongoing symptoms, uh, uh, huh, ongoing symptoms suggestive of ischemia, hemodynamic instability, and life-threatening arrhythmia. So we should not consider fibrinolysis after 12 hours. So this statement has class of recommendation 1, level of evidence C. Routine PCI strategy should be considered in patient presenting late, that is 12 to 48 hours after symptom onset. That is, this statement has class of recommendation 2A, level of evidence B. Routine PCI of occluded infarct-related artery is not recommended in STEMI patient presenting more than 48 hours of symptom onset without persistent symptom. So the class of recommendation 3 and level of evidence A. Now the transfer and intervention after fibrinolysis. Transfer to PCI capability center is recommended in all patients immediately after fibrinolysis. Emergency angiography and PCI of infarct-related artery, if indicated, are recommended in patients with new onset and persistent heart failure and shock after fibrinolysis. Angiography and PCI of infarct-related artery, if indicated, is recommended between 2 and 24 hours after successful fibrinolysis. Now regarding invasive strategy in NSTEMI. An invasive strategy during hospital admission is recommended in NSTEMI ACS patient with high risk criteria and high index of suspicion for unstable angina. That is class of recommendation 1, level of evidence A. A selective invasive approach is recommended in patient without a very high risk and high risk NSTEMI ACS criteria and with low index of suspicion for NSTEMI ACS. An immediate invasive strategy is recommended in patient with working diagnosis of NSTEMI ACS and with at least one of the following very high risk criteria, that is hemodynamic instability or cardiogenic shock, recurrent and refractory chest pain despite medical treatment, in hospital life threatening arrhythmia, mechanical complication of MI, acute heart failure presumed secondary to ongoing myocardial ischemia, then recurrent dynamic ST segment and T wave changes. This statement has class of recommendation 1, level of evidence C. An early invasive strategy within 24 hours should be considered in patients with at least one of the following high-risk criteria. That is confirmed diagnosis of NSTEMI based on current treatment, ESC high sensitivity troponin algorithm, dynamic ST and T wave changes, transient ST segment elevation, and Gray score of less than 140. Class of recommendation 2A, level of evidence A. So in next class, we'll discuss about the antithrombotic therapy.